on this. Now, shifting gears a little bit, you practice in South Florida, and there's a lot of sun exposure down there. And what do you see? Do you sense that the skin, the background skin, is so sun damaged compared to, let's say, I was at one point in New Jersey, the skin is not so damaged. And like I think to me, it's really difficult sometimes to tell those lentigo maligna. And how do you go about that to differentiate this?
So not all melanomas are the same. That is, we've learned that different melanomas have different gene mutations. And melanomas that we see quite often in South Florida are due to sun, but they're more an age-related problem. That is, these melanomas that we see in older individuals, we call them melanomas on sun-damaged skin, but they're particularly most common in our older population. So whether it's truly just sun-related, they do have distinct patterns. And usually with these types of lesions, we look for clinical clues. We look for the clinical clue of the color gray, and then we look for the dermoscopy clues, and they have distinct patterns as well. So by doing this, we're really able to separate out these early melanomas from just someone's sun-damaged skin from what we call age spots or solar lentiginous.
I think one of the things, I think that the folks out there should really sort of start to appreciate is the fact that, like exactly said, not all melanomas are the same, right? So those early lentigo maligna melanomas, those melanoma in situs, to me, they're very indolent, right? Once you remove it, they're gone. The risk of their spreading to the rest of the body is very, very low, right? And so I think a lot of people out there, once they hear the word melanoma, they get terrified. But everything you described, those kind of melanomas, they don't usually do much of harm.
Yeah, so these melanomas in our older patients with these melanomas on sun-damaged skin, they do have high cure rates, and they're very slow growing. That is, some of these individuals will have these flat patches of skin, which are actually early melanomas, for many, many months to sometimes years, in contrast to some of the other melanomas. Some melanomas are what we call de novo, where they just pop up on the skin. Some melanomas are associated with a previously existing mole. So they're all different types of melanomas. And then we have a type of melanoma, which is actually a shades of pink melanoma. We call these the pink panthers. That is, they're very, very difficult to diagnose. In those instances, we again also look for the dermoscopy clues because they too have a distinct pattern.
Yeah, I think that's the thing. This is one of those most difficult melanomas to diagnose, the pink melanomas. And the pink melanomas, there's just very little dermoscopic clues sometimes. And they're, the pink panthers, the mimickers, and very difficult. Couple of things. Coming back to the lentigo maligna, because this is really a unique type of melanoma that's not commonly sort of seen. The treatment for it is obviously surgery. And what do you recommend for patients when surgery is not an option? Either the patient is too frail or it is the tumor is too big.
So the overwhelming majority of melanomas on sun-damaged skin, in my opinion, Mohs surgery is the treatment of choice. And that's in the overwhelming majority. There are very few of these melanomas, at least in 2022, which can't be treated surgically. There are selective instances, however, where you can't. And in those instances, most of those types of cases, some individuals will use imiquimod, which is one of the medications which is used actually for basal cell carcinomas. And in a selective individuals, we might use that. Radiation therapy has been used in the past, but for the most part, I still believe that almost all melanomas on sun-damaged skin can be treated surgically. Now, the problem with treating these with your conventional surgical excisions is that high recurrences with a standard excision it reaches almost 20%. And that's why Mohs surgery, in my opinion, is the method of choice for these types of lesions, particularly on the face.
Yeah, yeah, totally agree. Totally agree. And I think the facial, I mean, I think we using the word Mohs surgery, and I think one caveat to add is you definitely really need special MAL1 stain or immunostain. Otherwise, it's sometimes a little bit challenging to tell the difference between real melanoma cells versus the artifacts from the freezing, right? And some other places that if you don't do Mohs, they do those kind of slow Mohs, meaning that they remove the cancer and then they send the rim of tissue to the pathologist and get permanent sections and look at it to make sure the margin is clear before doing the repair, in essence.
And so that's the other alternative, other than doing Mohs surgery, is, as what you mentioned, slow Mohs. And basically what you're doing is you're
Margin control, yeah.
You're surgically removing the melanoma, and you're getting what are called rush permanents, where you have your pathologist have the tissue back to you within a 24-hour period, where he's looking at the entire skin edge, and you're doing Mohs surgery in terms of looking at the entire skin edge on a 24-hour basis, as opposed to all in one sitting.